This time, I will talk on behalf of my team from Aweil, South Sudan, about our humble experience in care for children with type 1 diabetes, as an example of how we take care of those children in a resource-limited setting. For those who don't know Republic of South Sudan is a country located in the eastern part of the African continent. It gained independence in July 2011 after a long civil war. It lies over an area of more than 600,000 kilometers squared with a population of more than 12 million people. Unfortunately, South Sudan has worrying indicators, both economic and health indicators. We have a population of more than half of the population live under poverty line, and our health indicators are quite worrying in terms of high maternal mortality rate and high children mortality rate, especially under 5 years. MSF has been working in South Sudan for quite a long time. It's more than 3 decades, taking care of children and the vulnerable group in different areas. Currently, there are 17 projects run by different sections. And Aweil project, you can see the star here, is one of the biggest OCP projects in South Sudan. This is Aweil Hospital. It's a bird eye view. It's taken 2017 during rainy season. MSF has been there in Aweil since 2009 until now. And our project in Aweil is a medium to large size project made up of 172 beds, and we run the hospital in partnership with the MOH. MSF provides around-the-clock pediatric and maternal emergency care, and the hospital is run by a wonderful team of national and expatriate staff. I want to go back.
Okay.
We have 2 main departments in Aweil Hospital. We have the pediatric department and the maternity department. Thank you. And both of them are supported by other departments, like we have a medical laboratory and blood bank, the pharmacy, and other units. Our story with type 1 diabetes in Aweil is dated back to 2011. And at that time, our staff started to see many cases of children presenting with the diabetic ketoacidosis. And this compelled the team there to develop, to find a way to take ongoing care of those children. And as a response to that, we developed protocols and guidelines for both inpatient and outpatient care of children who present to our hospital with the diabetic ketoacidosis. And we shared those guidelines with other projects. Now we have like 50 children with the type 1 diabetes mellitus, and the number is quite undulating due to many factors. We have discharges, defaulters, and also deaths. But the highest number was 89. The youngest one in our cohort is 5 years, and the oldest one is 15 years, because we are focusing mainly on children with type 1 diabetes. And they come from different parts of Aweil, and also from very distant villages, and even some of them come from neighboring states, which means a lot of effort for them, very long distance for them to come and receive care in our hospital. The services we have in Aweil Hospital, we provide inpatient services, and we provide also outpatient services. For inpatient services, it's mainly for those who present with the DKA, and which is the very common first-time presentation for new cases. For that, we admit them in our pediatric ICU, and of course, this is MSF Paediatric ICU. And we use protocols to treat them and to follow up. And these protocols are really simplified. They are quite different from the protocols that we know in terms of management of diabetes. We use, for treatment, we use rapid-acting insulin as infusion. And we do monitoring like blood glucose, urinary ketones, and basic chemistry. And of course, we cannot do things like electrolytes not available or ABG. After stabilization in the ward inside the hospital, and then we discharge them and we schedule them to come back for regular follow-up every month. And these monthly follow-ups are to give them supply of insulin and also to try to discuss with the caretakers about the challenges they face and to emphasize on education and re-education. The kind of services that we provide are, according to a paper published in 2018, we provide minimal care. Minimal care, and we are somewhere in between A1 and B1, which means that still we have high mortality from misdiagnosis of acute complications and also serious early onset. Still, we are working hard. That's the setting that we have. We are working hard to improve. We have a lot of challenges that we are facing. We have the family-related and social-related challenges, like homelessness. We have also difficulty to coordinate the care, and some of these challenges are from our part, like continuity of clinician and the specialty of, or the level of specialty of the clinicians that provide the care. We have also general food insecurity that is related to the patient, and it affects how we give them insulin. And also we have other medical challenges like storage of insulin, which is a big issue. What we use now is we ask them to store it in traditionally made pot or clay pots. They are used basically for drinking, but still we are not quite sure whether they are effective in maintaining insulin. We have a lot of questions, ethical questions we ask ourselves, and we are being asked these questions. We have, for example, what to do after 15 years of age. We are mainly focusing on pediatric, and some of them will grow up to adulthood, and this is a chronic illness. So what shall we do, and for how long are we going to support them? And also, once we start a treatment, what is the importance to invest on a child and then, in the end, to give up? And also, we know that MSF will not stay there forever. What will happen if MSF leaves one day? And also, there is some conflicts of prioritizing. We are taking care of 50 children. MSF is taking care of thousands of children that most of them die due to other infectious diseases. So there is ongoing debate about how to mobilize our resources to allow these children to live a normal life. And maybe we need to lobby for that, as Helen mentioned. We need to challenge ourselves, and we need to work hard to make sure that those children receive the necessary treatment as long as possible. We believe that, in conclusion, we know that diabetes is a neglected non-communicable disease. And children with type 1 diabetes are at high risk. They can die of DKA, they can die of chronic complication. And we know that MOH is our partner, but the services provided by MOH are really weak, and we cannot rely on them totally. So we need to support them. In our project, we are aware that we are strong, actually, management of inpatient. We are fair enough in dealing with the complications like DKA, but we believe that we still have to work hard to improve our long-term and to move from the minimum level of care, at least to the intermediate, which is the recommended one, if we are looking for a better outcome. And the greatest challenge now is finding suitable longitudinal care for those kids. And for this, we believe that MOH is our solution to guarantee sustainability of care and treatment for those kids. Thank you very much. And this is the end.